All right, so let's talk today about physical assessment of the pediatric patients. And one thing that's difficult with young children is they're not communicating yet. So how are we supposed to know if they're sick if they can't tell us, I don't feel good? So there's some things that you can catch up on, like if they're no longer eating, and they have a good appetite and they stop eating, or they're just real lethargic and sleepy and they're normally really active. So there's certain things that you can pick up on to tell that they're not feeling well. So the first thing listed there is appetite. So diminished appetite would be a sign that they're not feeling well. Physical activity less than normal would indicate that they're not feeling well. And for level of awareness, with an infant, like 8 weeks of age and older, they'll follow you with their eyes when they're alert and noticing their surroundings. But if they're not feeling well, then they're not going to be looking for you. They're just going to be kind of just gazing non-specifically, not necessarily following you with their eyes. So follows with eyes versus staring forward would be a way of knowing their level of awareness. So following with eyes means that they're aware of their environment, following with eyes, versus staring straight ahead would mean they're not aware of their environment or decreased level of awareness. All right, as far as respiratory issues go, there's different symptoms that can point us to what could be going wrong. The first one is presence of a cough. So if you're hearing a very dry, persistent cough, that tells you that there's a pharyngeal irritation. So oropharyngeal would mean like a sore throat, swelling in the upper airway, you'd get a dry, persistent cough. If there's swelling around the larynx, then you're going to hear a harsh barking or brassy cough. It's like a when there's problems with the larynx. When there's a problem with the lower airways, especially with bronchospasm, you're going to hear high-pitched sounds and wheezing, whether on exhalation or both inspiration and exhalation. So when they're coughing, it's a wheezy cough. So that would be involving the lower airways. When you hear wheezing on exhalation, it's typically produced by intrathoracic airways, meaning the airways inside the thorax versus outside of the thorax, which would be part of your trachea and your larynx. So with wheezing, with exhalation, the airways narrow a little bit. That's normal physiology. When we breathe in, the negative pressure in our thorax pulls the airways open. And then on exhalation, the airways narrow a little bit when the air is coming out. So that's just typical physiology. So breathing in, you may not hear any wheezing, but on exhalation, when the airways narrow a little bit, that's when you hear the wheezing. If you hear wheezing on inspiration only, that's produced by extrathoracic airways. So that would be everything outside the thorax, such as the first part of the trachea, the larynx. Because when you breathe in and create a negative pressure, it pulls in the extrathoracic airways. Do you need to clarify that in your notes at all? Like when you're breathing in, the negative pressure pulls the upper airway in. I know we talked about this in pulmonary function. When you're looking at different flow volume loops and you have narrowing, if you have like a tumor in the larynx or you have a vocal cord that's prolapsed, when you breathe in, the negative pressure pulls it all in and it's harder to breathe in. And then it's fine on exhalation. So it's opposite outside the thorax compared to inside the thorax. you're okay with that. Some patients that have narrowed airways from bronchospasm, you'll hear no airflow. So you'll listen to the chest and not hear any air moving. So you have to know when it's not just like an old COPD patient where you usually don't hear air moving versus a younger person where you would expect to hear air movement and you hear none. So that would indicate that the airway narrowing is so severe, there's no air going in and out of the airways. And then you'll notice sometimes you'll give a bronchodilator, and then after the treatment, it sounds worse. It's like, oh my gosh, this bronchodilator made everything worse, which isn't the case. What has happened is now you do have air movement. So because there's air moving in and out of the airways, it sounds like the wheezing got louder, but air movement has actually improved. All right, then you look at work of breathing. So having dyspnea, shortness of breath, or labored breathing, and all different terms used to describe it, you will see sternal retractions. So again, the sternum gets pulled in. And the reason that happens is when you generate a large negative pressure in the thorax, that negative pressure can pull in a soft rib cage. So in infants, young children, you'll see the sternum go in when there's high negative pressure being generated to try to get the breath in. So in severe bronchospasm, obstructed airway, you're going to see that. Nasal flaring is obvious. It's just something that's done subconsciously. When you're really hungry for air, your nostrils flare. So that's typical. Short sentences or short cries indicate that there's difficulty getting the air in, and there's also difficulty getting the air out. So that they'll talk in short sentences or they'll have short cries. Okay, I had one more item added to that list and it's not on there. So after short cries, I have also intercostal retractions. So if you could add that to your notes. And then also a note about oxygenation. When there's mild hypoxemia, typically children become like irritated and more active. And when the oxygenation becomes severe, like really bad oxygenation, at that point then they become limp or moving less. So in my notes I have mild hypoxia causes increased agitation. So I'll give you a moment to write that down. Mild hypoxia causes increased agitation. And then write, for another bullet, increasing hypoxemia and hypercarbia, so the CO2s are starting to climb. Baby becomes lethargic. So it's almost like you want to see them agitated because you know they have air exchange, you know they're getting oxygenated. It's when they become limp or lethargic that you're more worried. Rather than, oh, look, they're doing better, that's when you become more worried if they're not moving at all. Here's a question. What causes paradoxical chest movement for infants and young children? What causes paradoxical chest movement for infants and young children? So paradoxical would be, typically when you breathe in, you've got your chest and abdomen going out at the same time. Paradoxical would mean that you're breathing in, but your chest doesn't go out, but your stomach does, and it creates a paradoxical type movement.
Could it be that there's some form of obstruction causing there to be like they're like pulling, trying to pull air in?
Yes. So airway obstruction is one, and low lung compliance is the other. This is just a picture showing what we were talking about when you have airway obstruction outside of the thorax or extrathoracic versus, this is only showing extrathoracic. So breathing in, it causes the extrathoracic airways to narrow. So to recognize normal vital signs for different age groups, it's nice to have something to go by as far as what's considered normal. And for pulse, when a baby is born, do you remember what the normal heart rate is for a newborn? We'll say like
120 to 180.
120 to 180. And so really fast heart rate for smaller organisms. And as the organism grows, you have a slower heart rate. So by the time the infant grows to be 2 years of age, a normal heart rate is 110. So you remember the neonate being normal, and then at 2 years of age, 110 is normal. By the time they're 4 years old and 8 years old, now it's to normal adult heart rate. 100 at 4 years and 80 at 8 years. With blood pressure, there's a formula to use. So you can write this down. BP for ages 1 to 10 years. BP, or blood pressure, for ages 1 to 10 years is 90 plus 2 times age in years. So 90 plus 2 times the age in years. So and then underneath that write diastolic range. Diastolic range, approximately 30 millimeters mercury less than systolic.
You said 30 millimeters?
Yes, 30 millimeters less than systolic. So let's see if what we have written here on this PowerPoint slide is accurate. Let's figure out a 4-year-old. 90 plus 2 times the age of 4.
98.
98. And 30 less for diastolic, so 98 over 68. And the 4-year-old here has 95 over 65.
That's roughly the same.
Yeah, so the formula gets you pretty close to what normal values are. So what would be the highest blood pressure for a 10-year-old?
120 over. Yeah.
120?
110.
2 times 10 is 20. 90 and 20. 110?
Yeah, 90.
110 over
80. Yeah.
80. All right, and then respiratory rate, again, it goes down the older the person is. So a normal respiratory rate for a 2-year-old is 28 breaths per minute. By the time the child is 8 years old, the respiratory rate is 20. And I think for the adult, we say 12 to 20 is a normal respiratory rate.
Mm-hmm.
So an 8-year-old has very similar vital signs to what we consider normal adult vital signs. Another way to notice if blood pressure is adequate is by checking capillary refill. So, I don't think I added that to the notes, so you have to write it. Okay, so write this down. Capillary refill. You press on the skin until you see blanching. blanching, blanching. So you press on the skin until you see blanching, and then you let go. And in less than 2 seconds, the color should return to that area. So in less than 2 seconds, color should return, meaning that you have good perfusion. So in less than 2 seconds, color should return. This means there's good perfusion. So there's adequate blood pressure, the blood flow to the area is good. Should pink up in less than 2 seconds. And then write greater than 2 seconds. Indicates poor perfusion. Greater than 2 seconds indicates poor perfusion. So typically you see this applied when infants or young children go into shock, where they have a really massive infection in the body, septic shock, and blood pressure is dropping. A quick way to evaluate whether they're perfusing well is by doing the capillary refill. So rather than having to take the blood pressure and check the blood pressure, you could get a quick glance as to how they're doing just by looking at capillary refill. All right, now we'll talk about causes of upper airway obstruction. And of course, with a small airway in infants and children, when there's some inflammation, it can go from being mild to severe very quickly. So that's why you always have to be paying extra attention to infants or young children that have a cold, because it can progress very quickly to where they have airway obstruction. All right, so the first type of airway obstruction is called Croup, and the medical name for that is laryngotracheobronchitis. So you have inflammation of the larynx and the trachea and the bronchi. When you have swelling of these structures, then you have a small potential for ventilatory and oxygenation failure. All right, this occurs in children. It says 6 months to 6 years, and I know even the textbook says 6 months to 6 years, but it's typically, you see this in younger children, 6 months to 3 years. So the incidence after 3 years is very minimal. So what I'd like you to do is change that to 3 years, just so you're going to connect Croup with the younger infants, and then we're going to talk about epiglottitis, like swelling of the epiglottis with older infants. All right, so the small potential for ventilatory and oxygenation failure, this rarely leads to respiratory failure and intubation. 85% of patients that come into the ER with Croup end up going home within 2 hours. Only less than 1% have severe Croup where they actually need intubation. So it's a common occurrence, but rarely does it need intubation and ventilation. How to be in respiratory distress and still be happy. hear the wheezing on inspiration and on exhalation? So does that give you a clue as to where the narrowing is coming from?
Mm-hmm.
That it's extrathoracic or up in the larynx? Okay. All right, so the cause of croup is a virus. It's called para-influenza virus. In 74% of cases, there could be other causes of croup. The respiratory syncytial virus, we'll talk about that. Mycoplasma pneumonia can cause it. The patient presents with a brassy cough, hoarseness, inspiratory stridor, sternal retractions, and a 2-day history of low-grade fever. So before I click on that link, just to make sure that you recognize the signs of croup. So the brassy cough and the hoarseness come from the laryngeal narrowing and all the swelling in the larynx. The sternal retractions come from the airway obstruction. Again, they're trying to breathe in, but instead of the air coming in, it just pulls the thoracic cage in. Having a 2-day history of low-grade fever is really important to remember with croup. So that's the presenting history. Oh, the baby's had a mild cold for 2 days, and now they're getting worse. So that's typically how long it takes the swelling to occur in the larynx. So 2-day history of low-grade fever. And then let me tell you about spasmodic croup. There's spasming of the larynx. So it's not due to a virus, it's just spasming of the larynx. Distress, and then for some reason it just clears up and the baby's fine. So it's recurrent with no history of any prior infections. So I just have in my notes, spasmodic croup is recurrent, not caused by infection. I don't have why it's caused or why it happens. I just have that it's not caused by infection. All right, so let's see what this shows us. The rail. Okay, this is stridor recorded over the trachea of a 15-month-old girl with croup. So you hear the hoarse sounds. Is it equal on inspiration and exhalation?
No.
It's a lot more louder in inspiration.
Inspiration.
Yeah.
So it's extra thoracic.
Very good. So the diagnosis for croup is based on the chest x-ray, which is coming up, the history and physical findings. So the age of the infant, the fact that they're between 6 months and 3 years of age, the hoarse sounds, the barky cough, low-grade fever. All right, so how do you treat croup? I think I told you already that hospitalization is necessary if stridor is present at rest, or 1% of all hospital ER visits end up needing to be hospitalized. For steroids, it says systemic, inhaled. What's the question? So to give steroids by inhalation, that works well in the ER to reduce the inflammation. So what steroid could you have the infant inhale in the ER? Flovent by MDI, nebulized. I don't want to have to give you guys the answers, but can you think of any steroids you can nebulize to reduce inflammation? Yes, Pulmicort. So you could do that in the ER. And then systemic steroids are usually ordered for the infant to go home with, because remember, steroids will reduce the inflammation. Another medication that will reduce inflammation is vaponephrine. Do you remember that vaponephrine has alpha constricting properties along with beta 1 and beta 2 properties? So it's the alpha 1 properties that cause vasoconstriction of the
Inflamed area.
yeah, of the blood vessels in the inflamed area, so that reduces the swelling. And what is the dosage that you would order for an infant?
Of vaponephrine.
Mm-hmm.
Half of 2.2 tons?
Yeah. Yeah, so the racemic epinephrine comes in a 2.2% solution. Is that what you've seen?
Mm-hmm.
And you would give 0.5 mLs of the 2.2% solution. And then the textbook says you can use up to 1 ml per treatment. But what is the side effect with delivering racemic
Increased
epinephrine?
heart rate.
Yeah,
So you have to monitor your heart rate
yeah,
to make
it
sure.
causes a lot of tachycardias with this medication. So it would be better to give 0.5 mLs, wait a little while if that doesn't help, and then just repeat the treatment rather than giving 1 ml completely at one time.
Right.
And then use oxygen, keep oxygen saturations greater than 95%.
Would you also use Helios?
And you could use Heliox, yes. I have a question here. Why would you use vaponephrine and not just use albuterol? Do you know the answer to that?
Ultra fast.
Well,
One is faster than the other?
albuterol.
It's really fast, yeah.
But that's not the
But
actual
albuterol,
reason.
doesn't that work in the,
Racemic?
albuterol is working in the lungs versus constricting vessels? Because racemic epi is constricting vessels versus,
Racemic has the alpha 1.
Yes. So the reason racemic epinephrine is better than albuterol is because racemic epinephrine has the alpha 1 properties to it. Albuterol is pure beta 2 stimulating properties. So albuterol would not help with airway obstruction,
right.
upper airway obstruction. Okay, so we've got a baby in the emergency department with a croupy cough, and we want to evaluate them to see how severe the croup is. All right, so I want you to throw out some suggestions. How would you determine if the croup is so severe that we need to be admitted to the hospital, or we just send the baby home? What would you look at? The sex?
Saturation?
Oxygen saturation? Okay. What oxygen saturation would indicate that they're severe? Severe croup.
Less than 90%.
Less than 90%? Okay. Now, what if it was 93%? What would that mean? We know that normal would mean, hey, they're not so bad, right?
Yeah.
And then as it diminishes, O2 saturation diminishes, that indicates that they're more severe with respiratory distress. Okay, so O2 sat, what else?
At rest, their stridor is like both inspiration and expiration.
Okay, so if you could hear the stridor without your stethoscope, that would mean more severe than if you need your stethoscope to hear stridor,
Right.
right?
Mm-hmm.
Okay,
Sternal retractions?
sternal retractions
Or work of breathing?
and work of breathing.
Paradoxical.
I think you hit them all. Okay, there's two more.
Lethargic.
What?
Lethargic.
Yep, level of consciousness. So what if they're lethargic and not responding very well? Does that indicate more severe?
severe,
Yeah. Yeah, very good. Okay, one more.
Hypercarbia.
What could you
Yes,
determine?
but that's not on the list.
What did you say?
So before you get a blood test,
Hypercarbia.
how could you assess the infant to determine how bad the croup is?
Their chest movement?
The following of the eyes, or is that level?
That would be level of consciousness. How about listening with a stethoscope
Oh,
to breath sounds?
yeah, that works. Auscultation.
That's good.
So if you don't hear any ear entry, that would be more severe than hearing diminished breathing. And so most children are treated successfully in the ER, vaponephrine, Pulmicort. If retractions in the stridor continue after treatment and 2 hours in the emergency room, the child will be admitted for closer observation. All right, so this is the chest X-ray, and can you?
That's the neck. No.
Oh. I stand corrected. So here is a neck X-ray. Where's the chest? I love it. So you can tell that there's narrowing because where there's black, that's air entry. And notice up here how narrow or how obstructed the upper
Looks
airway
opaque,
is.
too.
So this, they call this the steeple sign,
Steeple?
S-T-E-E-P-L-E, like a church steeple. I guess a church steeple is narrow at the top. So this looks like a church steeple.
Interesting.
Oh yeah, down here it says steeple sign. When you have a steeply angled subglottic wall from swelling. Another picture of the same, where there's just a lot of swelling in the larynx. Okay, next one is epiglottitis. So obviously this is swelling of the epiglottis. It occurs in children that are a little bit older, 1 to 5 years typically. It's no longer a frequent occurrence in childhood because of the vaccination